With immense pleasure, I would like to invite upon Dr. Gagandeep Brar. He is the co-founder of Sangam Netralaya for his talk on topic Tips for Phacoemulsification for Young Beginners.
Thank you very much. Thank you to Professor Suresh Gupta and Professor Parul as well as GMCH for having me here today. And my apologies for intruding into the glaucoma session. So essentially, I saw a lot of you doing wet lab as well. So all of us are trying to learn the art of cataract surgery, which is the basic thing you need to know as an ophthalmologist. So I'll just quickly go through these stages. Most of us are somewhere here. Some of you are at stage 1. Abhi nahi aata. I wish I could do it. And somebody like me maybe has just about crossed that stage to go on to this. And we have a long way to go down the line. So that's where all of us want to reach, but it takes a lot of time and effort to do it, and the focus. And for you guys are actually exposed to only the phacoemulsification. You haven't seen the era of intracapsular cataract surgery, extracapsular cataract surgery. Phaco, surprisingly, because it's a totally closed chamber technique, is actually easier than what we used to do earlier. And obviously, this is the surgery of today. This is what the patient wants. This is what you want. So we are essentially, especially those of you who are going to end up in cities, practicing in cities, those of you are not going to go into the underserved areas. This is the technique you need to know how to do. And when to convert to phaco for your generation, it means somebody who has been doing the small incision manual cataract surgery and wants to go on to the phaco part. Can do that well, but yet cannot do a good phacoemulsification. And this is what we all need. There will be some hitches as we go along, but we have to overcome all those. And our main considerations in the beginning, most of you already know it. These are given. You can't be doing in the beginning, you don't want to select a patient which is going to be difficult even for an experienced surgeon. So patient selection is very important. And out of practically the steps of phaco, I would say one of the most crucial is this. Capsulorhexis is the fulcrum of a good surgery. If you achieve a good capsulorhexis, that's half the surgery already over. And obviously, nucleus management, that also with the first good crack, the surgery is practically over. As far as patient selection is concerned, you want a patient who is not very demanding. Good exposure. Make sure you don't select a deep set eye, some tricky S is going somewhere, and use a speculum which does not pressurize the globe. And a jointless wire speculum is a good idea. I have used a self-retaining speculum. I don't like those springy kind of things. So the one with the screw actually works very well, for me at least. Cornea clear, pupil well dilating, a grade 2 to 3 nucleus, in the logs 3 maybe going up to 4. Red reflex is really not that much of an issue in today's time because we have the availability of these capsule staining dyes. And don't select the ends of the spectrum of grades of cataract. Not very soft, not very hard, because the soft cataracts are also going to give you a lot of trouble. Later on, you will like the soft cataracts very much because they are out in a few seconds. This is really not in your hands. This is largely in the hands of the institute where you work. But they do help. A good microscope and a good phaco machine also helps in shortening the learning curve. Try to relax. It's good to, it's easy to tell you, but this is not easy. At least in the beginning, it's not easy. There's a stress in your system. Make sure the patient has emptied the bladder, because in the beginning it's going to take sometimes more than an hour. and this thing applies to you as well, right? So both the patient and you should be relaxed. Pupil dilation, whatever you use, it needs to be a good pupil dilation. Check your machines, instruments, availability of lens and everything beforehand. So you can't be during the surgery, you can't be deciding, oh lens कहाँ है, वो ये वाला lens तो है ही नहीं, ये power नहीं है, lens गिर गया, टूट गया, backup है नहीं, पीसी टीयर हो गया, किसी को पता ही नहीं है, विट्रेक्टमी है ही नहीं हमारे पास, या ऑन ही नहीं की किसी ने. So you can't be getting into those things. Everything has to be ready in time before you start the procedure. Don't trivialize the surgery. We are all culprits in trivializing cataract surgery for a patient. 5 मिनट लगेंगे, experienced one will say कोई problem नहीं है, कराओ कोई issue नहीं है. Remember, it's a major procedure for the eye. A lot of things can go wrong. So do not trivialize this surgery for the patient. And counsel the patient regarding hygiene, morning breakfast, systemic medications and everything. I for myself do not take the history of any systemic medication because they practically have no bearing on your surgery. The flax, IFIS, the floppy iris syndrome, also the ones who are taking tamsulosin or any of those alpha blockers, even if you stop them, it doesn't change anything on the table. So I don't ask the systemic drug history at all. A lot of patients will ask you, aspirin band karni hai ki nahi karni, blood thinner band karna hai. For routine phaco, where you are going to do a clear corneal incision, no need to stop those things. And explain the need of the patient lying still for about at least half an hour. Infection control, I'll just quickly, you can read it, we'll go through it. This is the most important thing. So a drop of povidone iodine 5% into the conjunctival sac is the only proven thing in reduction of endophthalmitis during cataract surgery. Everything else is additional to this step. And draping and everything should be meticulous. If you are happy with the half exposed eye, incision drape going somewhere, the cilia out of the incision drape, that means you are not a meticulous surgeon. So even the smallest of things should bother you. It has to be perfect from the very first step. Obviously no topical anesthesia, that's going to come much later. So a good anesthesia is what you want, and good anesthesia means good akinesia. The anesthesia part, even if you put a drop of paracaine, the patient doesn't feel it too much as far as phaco is concerned. But in the beginning, you need good akinesia. If the eye is moving here and there, as a beginner, you will find it difficult to do the surgery. Intravenous sedation is a good idea. I don't know, some places practice, some don't. But I have been very comfortable with giving intravenous midazolam 1 to 1.5 cc for all patients. They feel much more comfortable during the procedure, especially if you are going to do a topical anesthesia phaco. And a qualified anesthetic support. I would say especially in institutions, this has to be there, should be there, even though you are doing a 5-minute procedure, anesthetic support should be there. I've already discussed this. Draping, patient should be lying comfortably. This depends upon which side you want to place the microscope, as well as the phaco machine depends on what kind of a surgeon, you are right-handed or a left-handed surgeon. If you dim the OR lights, it gives you slightly better contrast. There should be no clutter of wires everywhere in the OR, especially when you finally let's say you are operating in the evening, you are the only one left and there are some sisters there, nobody is senior to you. As a general rule, the OT layout should be a very clean place and have a comfortable height adjustable operating stool and chair. You need to be sitting comfortably. If you are looking up like this or you have to bend down a lot, you are already uncomfortable. And the rest of the surgery then does not proceed very well if you are already uncomfortable. For an incision, I think the clear corneal incision is what you need to learn. Scleral tunnel as a theory is a good idea. People used to tell us that a scleral tunnel is better for beginners. But believe me, scleral tunnel phaco is far more difficult than a clear corneal phaco. And a temporal incision is what you want to finally do because it is more astigmatically neutral. But not only that, but even as a beginner, a temporal incision will give you much better access to the eye. And whenever you have to manipulate, your manipulations are so much easier with a temporal incision. And aim for a square incision. So a squarish incision is more stable, more astigmatically neutral, and for the minimum 1.5 millimeter valve is required for the main incision. If you have too short, you will get into trouble. It's a leaky incision. If you have that, you can suture that and use another place to make another incision. And good incision obviously is also one of the crucial steps. 2.75 to 3, this is 3 is a little too much travel into the cornea. I would say something like a 2.5 millimeter travel is fine, especially with these newer blades. When you are doing a 2.2 millimeter phaco, you don't even need to go that. So a 2 millimeter travel into the cornea is fine. And some keratomes have a mark to guide the amount of travel within the cornea. Now these are videos almost 20 years old. So you will see this keratome has a mark here. You see that? That kind of tells you how much travel you need to go into the cornea before you dip into the anterior chamber. So 2 planar incisions, 3 planar incisions are described, but what you saw here was an initial small groove like this, then you go within the lamellae of the cornea, and then you create a small dimple into the posterior lamellae of the cornea, and then you go in. Once you go in, you are almost at that point of time parallel to the plane of the iris. You don't want to poke towards the crystalline lens. Similar, same keratome. This was, I believe, in those days a 2.75 or 2.8 millimeter keratome. I still use a 2.8, it works fine for me. And that's a kind of dimple that you see at that point. And then you enter, and by that time, the blade is very flat and in plane with the surface of the iris. We will skip this. We are not going to learn a scleral tunnel incision at all. But I still do sometimes for patients who have had an RK, you might have to still do a scleral tunnel phaco there. You can't do a clear corneal because those things will open up. And sometimes in kids, you might end up doing a scleral tunnel phaco. Side ports are not difficult. You just have to go parallel to the plane of the iris and you will automatically have something like a 1 millimeter valve. And you don't need a very wide incision. Slightly wider incisions will be required if you are going to do a bimanual IA. But if you don't use a bimanual IA, you use a coaxial irrigation aspiration system from the main incision, then you have only one side port and smaller than for a bimanual incision. More important than that is the angle between the main incision and the side port. If the two are less than 30 degrees apart, then you are going to get into trouble. Your hands go like this and it's very difficult to manipulate. And if they go too far apart, even then you will find it difficult to chop and manage the nucleus if the two go 90 degree or more than 90 degree apart. So the ideal would be something like a 45 to 60 degree angle between the two. Surgeon preferences, a little bit here or there you can manage, but don't go too far low or too far high as a angle difference between the two incisions. So side port, like I said, you just go parallel to the iris, not difficult. Again, you can use an MVR knife as well, which gives you very controlled size of the incision. But even if you are going to use a 15 degree knife, you know how much to make. You need something like 1.25 millimeter side port. And for bimanual, you want them to almost like 180 degree apart if you are going to finally use a bimanual. Most of you know that if you have a wide incision, it is leaky. If you have a tight incision, especially the main incision. It will compromise the fluid flow into the eye, chambers get shallow, you will get into trouble with both of them. If you have a very wide incision, you can suture one end of the incision, still use it. If you are not happy, just suture the incision, go to another place, make another incision. And side ports, obviously, you can abandon much easier than the main incision. Too shallow superficial flap can get cut, so you want to go at the correct depth and the correct place to do it. Too deep, premature entry into the anterior chamber, short tunnel, wound lake. This is the most crucial step of surgery. I already highlighted it. You can perform it before creation of the main incision or after. It's your choice. If you are going to do it before the main incision, then you will need to use either the needle cystitome or the 20 gauge or capsular access forceps, which some surgeons do use. I go from the main incision, so my CCC is after the main incision. The advantage of doing it before the main incision is that the chamber is very well maintained, even if you are using methyl cellulose as the viscoelastic. But in today's time, you do have very cost effective sodium hyaluronate 1.4% available. As beginners, it's a very good idea to use those. The chamber stays rock solid, so you can do your capsular access very freely if you are using that kind of viscoelastic. Clockwise, anti-clockwise, very personal, but most of us are used to a clockwise, anti-clockwise rexes. Why? Because when we write everything, we write an O, it is always anti-clockwise. We write an A, it is anti-clockwise. So most of what we write, most of them are anti-clockwise. So our hand is quite comfortable doing this rather than the other way around. The other way around can get a little difficult for some of us. Don't bury the needle into the cortex. It fluffs up the cortex and then you can't see what is going on. But in the beginning, I would say, if you find it difficult, you can stain all capsules. Even if you have a good red glow, you can still stain the capsule lightly, and it will help you in visualization not only while doing the CCC, but even afterwards. It will be visible to you throughout the procedure. So go ahead, use a trypan blue in all the cases, no problem with that. It is very safe. Always have a large flat flap. If the flap is not lying on its back and large flat flap is not visible to you and it is getting bunched up, then you will find it very difficult to control the rexes as it proceeds. So this is somebody else doing, I don't do with a needle. So the first thing is to get it flat on its back and then take it around. You see the surgeon is holding close to that point and it's a kind of a tangential force which is taking all around, right? The rexes you have all of you have seen, a centripetal force will make it turn inwards, a tangential force will make it go around in the intended circle, or if the chamber gets shallow, it starts going radial. So whenever it starts getting too big, you have to bring it inwards with a centripetal force, and if it is getting too small, you take a small tangential kind of movement, all the time making sure that the chamber is well formed with viscoelastic. And if you use sodium hyaluronate, that will make things quite easy for you. Main incision, you can use the regular utratas or from the side port with the capsular access 20 gauge capsular access forceps. Grasp, grasp technique, I mean you need to do it in 2 or 3 places at least, hold it again and again, because if you try to do it in one go, then it is difficult to control it. So you can make an opening in the beginning with a needle. Some people do this opening with the forceps itself. I do it now in these days with the keratome, the one which makes the main incision, goes ahead into the middle and opens up the capsule. You just hold it and then it's a tangential force, as you see here, grasp, re-grasp, again tangential, grasp, re-grasp. And main thing here is in the subincisional part. In the subincisional part, if you want to, let's say you are starting from here. You are starting from here. You don't want, with a regrasp, you don't want to leave it right here, because in the subincisional part, it gets difficult to regrasp. So you want to start your, let's say, regrasp somewhere here and then take it all the way around beyond the main incision. So don't leave it in the subincisional part. It gets difficult to regrasp at that point. Similar thing, this is, as you see, it's an angry posterior polar cataract. So you go in there, you want to hold it here and then leave it somewhere here, regrasp, take it around, and as you get more experience, you can size and center it as you go along. Till the time all of us start doing with the femto laser assisted surgery, this kind of a rhexis is not easy finally. The only thing is initially make sure of a few things, make sure the chamber is well formed, and if it is trying to go out, then you bring it in with a centripetal force. Remember, once you are having a supervised surgery, even if it goes out radial, that's not the end of surgery. The experienced surgeon who is working with you will be able to bring it back in most of the cases. So I don't actively train students now, but when I used to, I would let them do the rhexis. If it goes out, doesn't matter, right? I don't want to take over every time it's trying to go out, because then that fear starts developing in you and then you can't do it. So I would allow the student to have it go out and then know why it went out, so that the next time he or she makes sure that it doesn't happen again, and it can be brought back from practically anywhere. Size and centration is very important, and this is the main thing. If you have a small rhexis, you are in big trouble. Every step of surgery will become difficult. So if you have, let's say, stained it and you realize your CCC is maybe 3.5, 4 millimeter in size, rather than try to continue with that, you can actually put in more viscoelastic, make a small cut in one end with a vanas, hold that small tag and slightly increase the size of the CCC. If you can't do it, obviously your trainer will do it for you, but don't start surgery through a rhexis which is smaller than, let's say, something like 4.5, 4.75 millimeter in size. It will become very difficult. All the steps of surgery will get difficult. Large rhexis is also a problem. The nucleus wants to jump out every time from the capsular bag, but still it's less of a trouble than the small rhexis. If it comes in front, your cataract is not very hard, you will still get away with it with an anterior chamber kind of phaco. The cornea can still withstand it. But if it's a hard cataract, then it's better to be done within the capsular bag rather than out of it. And obviously, eccentric rhexis and everything leads to a greater chance of decentration and PCOs and stuff like that. Hydrodissection, I have written here, I don't know why I wrote that it's a bugbear for beginners. It's not a difficult thing to do. You just go underneath the edge of the CCC, lift up the capsule a little and inject. The only thing you have to be careful about is that you don't mistake a passing of the fluid through the cortical layers for a posterior wave. The posterior wave should be clearly visible to you, and once it goes, you can also see a gentle lifting of the nucleus, and also a sign which is very clearly tells you that the hydrodissection is complete is when the nucleus lifts, the superficial epinucleus develops a split. I don't know whether you have any time noticed that when you do the hydrodissection, the epinucleus which is covering the anterior aspect of the nucleus, it opens like a pea pod, and that tells you that the nucleus has lifted and it has opened up that epinucleus. Go beyond the CC margin, lift the anterior capsule a little, don't inject into the cortical layers. You can get mistaken by a fluid wave within the layers. Lifting of the nucleus I already said, and if it doesn't happen from one side, you can go another place and do it. Just make sure that it is complete. Go just beyond the, you can see that posterior wave, you saw that, and you also saw a hydrodelineation. So not all cases you will get that golden ring, but in the beginning I have found that doing a hydrodelineation makes things a little safer for the beginners. Why? Because one thing, it clearly delineates the edge of the nucleus for you. The other thing is that the epinucleus is a kind of a cushion. It doesn't, the whole, especially towards the end of the nuclear emulsification, the capsular bag doesn't flap as much, because now remember there is a epinucleus along with the capsule, so it doesn't flap that much if you leave it behind for removal at the end of surgery. Hydrodelineation, later on you may let go of this, but in the beginning it's a good practice. Golden reflex or golden ring obviously tells us that the thing is complete. The only downside is that the epinucleus which is left behind by hydrodelineation in the beginning, it may be slightly difficult for the beginner to remove. So same case, you saw that posterior polar. All of you know that you should not do a very aggressive, at least a very aggressive hydrodissection there. So you do only a hydrodelineation into the layers separating the nucleus from the epinucleus. Nuclear rotation in the beginning is a good idea to ensure that there is good nuclear rotation before you start the nuclear emulsification. But as an experienced surgeon, once the hydrodissection is complete, then the nucleus will rotate. So you can straight away go and do a chop. Here are 3 techniques. I find it very interesting that we were taught that this is the technique to start off with, and then you slowly graduate on to the other 2. But I have realized, even as an experienced surgeon, this is much more difficult to do. The divide and conquer. You have to go much deeper. And the beginner is so afraid of going through the posterior capsule, he or she will always end up with a very shallow groove and then try to separate the nucleus. And it just does not want to separate. And the grades of cataract that you select in the beginning, they are not very hard. And you end up with a bowl of nucleus. So I have really never taught this technique. For me, it's a historical technique. This is not something you will finally be doing as an experienced surgeon. So I don't see the logic of learning something which you are never going to finally use. So it makes no sense to me. For me, it is always a combination of these 2. Even out of these 2, stop and chop again, the first half is divide and conquer. It's the same thing again. So I would rather teach students a direct chop than a big trench and this. So I may be slightly different in my approach. I am not saying that these 2 techniques don't work. There will be a lot of experienced surgeons who do very good divide and conquer and very good stop and chop. But I have found that finally this is what you are going to do, and this gives you the whole nucleus still available to you when you hold and do the separation. So the whole nucleus is still there and you can hold it much more safely, and you don't need to go more than 50-60% depth. With divide and conquer, you need to go almost 80% depth. Must know machine parameters. I will not go into phaco dynamics here. You should know your machine, what it is going to do. And foot control is very important. For all the first years, I saw the first years doing some of that wet lab over there. If I don't know how to place my hands on the face and around the eye, I have no idea of the foot switch. It makes no sense to me of trying to emulsify the nucleus. It makes no sense to me. The first thing I want to learn is how to sit on that hot seat, how to place the hands more comfortably, where to make the incisions. That is more than enough. The rest of it comes later. So we get carried away by the nucleus straight away. That's what we want to crack, and that's the surgery. But that comes much later. The first steps are how to place the hands. If your hands are in the air, one hand is holding the phaco probe, the other hand is trying to stabilize that hand, that's not going to work. And you are learning the wrong things. So the first thing is to learn how to place the hand, where to make the incisions, and how to sit comfortably, use the microscope, use the foot switch. Because it's exactly like driving a car. It's exactly like driving a car. You have a car, it can go at 100 miles an hour, but you will have to at times drive it at 10 kilometers an hour. You press a little bit on the accelerator, it goes faster. If you don't put the brake on time, you will have an accident. So you need to know these things before we go on to the next steps. All history. So you can read, most of you know what divide and conquer is, right? And it's the deepest in the middle because that's where the posterior capsule is farthest away. This is the place where most of us make mistake. Here, even with direct chopping, we go through the posterior capsule somewhere here. Where the capsule is closer to you, you think you can go same depth, but this capsule is much closer to you. So towards the periphery. These are the major problems you face in the beginning. Inadequate groove, inadequate depth of instruments, nucleus too soft or too hard, and it just refuses to break. And believe me, if you have a bowled out nucleus, then it gets difficult for even an experienced surgeon to complete the surgery. It's not easy if it gets bowled out. You keep on just rotating it, trying to hold some place, it doesn't hold, it bowls out even more and just refuses to come out. I already said you can go through it. We'll just skip through these slides quickly. Chopping was described for the first time by Nagahara in 1993. And you need to go only about 50% depth. The beauty of it is you don't need to go near the posterior capsule at all. And chopper is introduced close to the phaco tip and then the two are separated laterally. Chopping is always a combination of basically forces. If you are using a very sharp chopper, you can go right in the middle almost and go right close to the phaco tip and simply separate. With a horizontal blunt tip chopper, you need to go more toward the edge of the nucleus and come in. But when you realize your movements, they are usually a combination of these two. You go a little towards the periphery, you go a little deeper and then you bring it in. So you can chop with anything actually. You can chop with a Sinskey hook, you can chop with anything which is bent down like this. Again 50% depth. The main thing is they have to be in line with each other. If your phaco tip is here and you introduce the chopper here and then you try to separate them, you will only torque the nucleus. It doesn't crack, it just simply rotates. So they have to be almost in line with each other. And this is like a direct chop. You go into the middle, introduce the chopper, not a very hard cataract, right in front of the phaco tip and simply separate. Okay. Now the thing here is not difficult in the sense that you have an idea of the bare part of the phaco tip. So you are going at almost like a 45-degree angle and entering the nucleus. So you are going to go only till the depth when the sleeve starts touching the surface of the nucleus. You know that is your end point. The harder the cataract, you can keep the tip, the metal part a little more bare. Softer cataract, slightly less than that. But something like a 1 millimeter, 1.2 millimeter bare area will be enough for you to go towards the middle of the nucleus, 50% depth. So the marker for you is the sleeve touching the nucleus at that angle. Again, you bury it into, the sleeve starts touching the nucleus. Just simply put your, and this is the grade of nucleus that you want to do. that's the color of the nucleus. That's the grade that you want to do as a beginner. Gray colored nucleus, maybe a slight yellowish tint there. And the beauty is that you don't go into the periphery at all. You are not going anywhere near the posterior capsule at any point during your nuclear emulsification. So that's the only thing I want to teach my residents if I were to teach. So I'll just take you back a little. What I also used to teach is, let's say you want to mix the two. You can actually make a small subincisional kind of groove. In the proximal, maybe 1/3 of the CCC, you can make a small groove. What that will do is give you an idea of the depth of the nucleus. And then you can hold the front wall, because you have created a kind of a front wall. Then you hold it, again wait for the sleeve to touch the nucleus, and then you separate. I'm sorry I don't have that kind of a video here. I have it in one of the other presentations. This is a presentation almost 20 years old. Epinuclear removal, essentially this is important. Unless the epinucleus is very soft, you should not try to take it out with the IA probes. It takes a long time, doesn't come easily, and then you get frustrated. You will end up doing something which is not recommended. It comes very easily with the phaco probe. There are only one or two things to be kept in mind. Use the phaco probe. You can lower the machine settings, or you can go a little softer on the foot switch. The only two things is, never go beyond the CCC margin and never go deeper than the CCC margin. If you are at just the CCC margin, the front part will come very easily. Now, sometimes you remove the front part, the whole thing wants to tumble. Now, remember, I am at the moment slightly more experienced than a beginner. You don't want to go here. So for you as a beginner, if you are trying to remove the epinucleus, then this something like 45-degree area is the only place where you take the phaco tip. And then the subincisional part, if it is not coming after flipping, you rotate it. And it can be rotated. It is not difficult to rotate at all, as long as the chamber is well formed and you have a fairly blunt instrument in your left hand. You can use the chopper. If it is not very sharp, you can make the chopper horizontal, and then with the knuckle of the chopper you can rotate the epinucleus. Finally, cortical removal. A bimanual irrigation aspiration system for you is the best. Coaxial system will be later if you want to use it, because with the coaxial system the subincisional part will be more difficult. A bimanual makes the chamber very controlled and you can easily remove everything. Nothing is subincisional. Coaxial is faster, but comes in later. So almost 180-degree apart, you go to the opposite part underneath the anterior capsule. The only thing with cortical removal is, don't pull too much radially, because in the beginning your whole feeling within the anterior chamber is not that great. If you have stained the capsule, then it is slightly better, but make sure you are not pulling the capsule along with the cortex. Okay, so what I would say is, remain very close to this part. You have just held the capsule. The rest of it can be actually removed with just vacuum. It will come to the probe. If you pull it, you are looking at the CCC margin all the time and making sure that the CCC is not shifting. I've had students hold the cortex all right, but then also held the undersurface of the CCC and then pulled, and 180-degree dehiscence. So you need to go at slightly under the level of the CCC. Don't pull radially too strongly. Make sure you can see just the cortex coming in. IOL insertion, especially in today's time, most of us are using single piece lenses. If you can do the rest of the phaco, Putting in the IUL is not difficult at all. Just make sure the chamber is well formed. Most of them will not need to do this. This was a pediatric cataract surgery many years back, but these lenses, PMMA lenses, are no longer kind of used. So you either have 3-piece foldable lenses like you see here, and you have those single-piece lenses. The single-piece lenses are the easiest to put. You just have the leading haptic go into the capsular bag, and the trailing one, if you just dip it slightly, it just goes in, or you can dial it. It's your choice. So putting in lenses, the only tricky parts are these 3-piece lenses or PMMA lenses. You have to be careful that it needs a slight gentle posterior vector to the force. If you don't give a small posterior vector to the force, it keeps on rotating in the sulcus. And if the CCC is on the slightly smaller side, all the more difficult. Viscoelastic removal, not difficult, especially if you are using that sodium hyaluronate. All of it comes out as a bolus. The only thing is, if you are using methyl cellulose, it's a little more forgiving, and Dr. Faisal will not need to come in and remove that viscoelastic, because intraocular pressure after surgery, even with the retained viscoelastic, a little bit of methyl cellulose is still manageable. But if you leave a lot of sodium hyaluronate there, your pressure can shoot up quite a bit. So you remove from both the anterior chamber as well as from behind the lens. If you tap the optic a little, the sodium hyaluronate or more cohesive viscoelastic, they will come out from the sides all in a bolus. You may not need to go behind the IOL like you see here, because this movement initially may be a little tricky. Chamber formation finally should be watertight, and the only thing is, be careful while hydrating the incisions, right? A very deep injection may cause a decimase detachment. So when you hydrate the incision, it's always a good idea to be almost like pointing the cannula into the corneal layers towards yourself rather than towards the center of the cornea. I think that's the theory part. Too long.